Hi, my name is Karen Barnes, and I will be reporting on case one. We have AW, a 56-year-old Caucasian male, here today to establish care after having a heart attack 6 months ago. In May of 2018, he was admitted to the hospital. He had a TIMI score of 5, which included diabetes, hypertension, over 50% stenosis, angina, and elevated biomarkers such as troponin 1, troponin T, and elevated CKMB. His PCI revealed that he had multiple vessel occlusions, which were not favorable for stenting. His so therefore he was given a semi-elective coronary artery bypass graft and then discharged in a stable condition. Okay. Because he has been feeling fine, he has not seen his primary care physician in 2 years. So now AW would like to get some refills and only on those medications that are necessary for his health. Um, he is not compliant in taking his medicine due to forgetfulness because he forgets once or twice a week. Now, AW would like to take control of his life, of his health, reduce his blood pressure, and do all that he can to restore his health through lifestyle interventions. His past medical history is that he was diagnosed with hypertension and type 2 diabetes 3 years ago, and now he has a STEMI. He enjoys walking his dog for 10 minutes 3 times a week. He loves fast food and red meat, and has been tobacco free since 1999 and denies alcohol and drinking. His family history: both parents are living, both had a history of hypertension and dyslipidemia. His mother had a STEMI at 45. His brother had an MI at 55. AW has a penicillin allergy. In assessing his disease states, we have dyslipidemia and type 2 diabetes. His dyslipidemia is uncontrolled, which is confirmed by his lipid values of total cholesterol 219, his HDL 43, his triglycerides 180, and his LDL 140 milligrams per deciliter. There has been some improvement, though, in his lab values from May to November, especially for his HDL. His TIMI score of 5 indicates that he has a 26% of having a cardiovascular event. His ASCVD 10 risk score was 69%. He is currently taking atorvastatin 10 milligrams PO daily, which is appropriate but suboptimal. He is also on carvedilol 6.25 milligrams PO twice a day, which is appropriate and therapeutic. He is also on nitroglycerin 0.3 sublingually as needed for angina. However, he is not taking it. Our recommendation of medications is that the atorvastatin be increased to 40 to 80 milligrams daily for life. A high-intensity statin will reduce cholesterol by 30 to 50%, reducing mortality and morbidity. It has a rating of 1A, suggested by the JACE, the Journal of American College of Cardiology. We can reevaluate the lipids at 4 weeks, then 3 weeks. If triglycerides remain elevated, we can add a low-dose phenylfibrate. This has a rating of 2BB, also by the JACC. At this time, AW's heart rate and respiration is fine. He is asymptomatic. Carvedilol would need further evaluation for dose changes. And this rating is this rating is 1A by the JACC. We also should add aspirin, 81 milligrams daily to prevent clotting. And this also has cardiovascular benefits, which is rated 1A by the JACC. An alternative would be to use aspirin 81 milligrams daily along with clopidogrel 75 milligrams. And this is rated at 2B by the JACC. Now we may want to discontinue the ibuprofen because it raises the blood pressure, or we'll keep it up. We'll keep it elevated. We can change him to Tylenol. We also would continue the nitroglycerin and encourage its use. Lifestyle modification is also recommended. And this would include dietary changes of a low-fat and sodium diet, more fruits and vegetables, weight management, and an increase in physical activity 5 times a week for 30 minutes. To monitor these changes, we would obtain a baseline LFTs, liver function test, obtain a lipid panel, then reevaluate at 4 weeks after dose changes. On the carvedilol, we would continue to monitor for respiration and pulse, angina, and blood pressure at 4-week intervals. Now, in assessing the diabetes, his diabetes is uncontrolled, which is confirmed by a oral glucose tolerance test, which was 210, and his A1C, which was 9.4%. He is currently taking metformin 500 milligrams twice a day. We recommend that the metformin be increased to 500 3 times a day. Now, metformin is a first-line monotherapy option. However, his blood sugar is still under control, still uncontrolled. We can change it to an ER formulation to reduce adverse effects, and this is a recommendation with a rating of 2AA. Because it has been 6 months, glyburide 2 milligrams PO daily can be added. The rationale is that a combination of metformin and glimepiride has a higher profile of reducing blood sugar, weight loss, moderate risk of hypoglycemia, and is inexpensive. Well, why not insulin? We want to give the patient a chance of taking oral medications before moving toward a more intense therapy, such as insulin. And at this time, the patient desires to take more control of his health, so he may be more willing to take the medicine and follow the recommendations. We also need to add aspirin, 81 milligrams for cardiovascular benefits, and have patient check blood sugars with a self-monitoring blood glucose machine. Note, I am not trying to treat hypertension, but a ACE or ARB would help prevent future complications associated with diabetes, such as nephropathy or kidney disease. Lifestyle modifications would include a diet low in sodium and fat, weight management, blood pressure control, lipid management, and an increase in physical activity 5 times a week for 30 minutes. Here we would monitor the lowering of his blood pressure, lowering of his blood sugar, hypoglycemia, lactic acidosis, vitamin B12 deficiency, renal functions, and A1Cs in 3 months. In conclusion, our goal is to reduce AW's cardiovascular risk and reduce his mortality through increasing his atorvastatin and reevaluating his lipids at 4 weeks, the stress on his heart, evaluation of A1C in 3 months, constantly keeping in touch to check on his self-monitoring blood glucose reports and lowering of his A1C, and minimizing future complications of diabetes. Thank you.